Dr. Ola for a very nice presentation. And I'd like to present Dr. Sheren Elmasry. احنا مخلينك للآخر عشان نحلي بيكي جميلة جميلات عين شمس. والحقيقة التوك بتاعتها about infection which is the main problem in all burn units in the world. عشان كده مخلينا مش هنمشيكي على فكرة عشان لو عاملة حساب شايفاكي قاعدة تبصي في الساعة مش هتمشي. Okay, our talk will be about infection control in burn unit facility in عين شمس university.
أنا الأول بحب أشكركم جدا على دعوتي معاكم النهارده وعجبني جدا الثيم it's a multidisciplinary team for burn handling. مش تخصص واحد مش حد بعينه. It's a collaborative work between different specialties علشان the care of the critically ill burn patient ان احنا نقدر نتايدل over this crisis is very very critical. والحقيقه ان احنا نسمع بعض انا استفدت جدا النهارده من البريفيس برزنتيشن وهحاول اختصر علشان الوقت. طبعا الانفكشن in burn patients is a leading cause of morbidity and mortality. It's very challenging. Why? Because it hinders the outcome. Despite all the efforts that's put in the patient care, a single infection can lead to death. And the epidemiology of the infection in burn patients is influenced by various factors: the extent and depth, the presence of comorbidities, the age of the patient, and the quality of the burn care. As we can see, the incidence of burn patient increase with the burn surface area if it is more than 30% of total body surface area. Not only the burn wound infection, but also other infections are very serious, such as bloodstream infection, which is very common in these kinds of patients. So in general, we can see that several studies have addressed the epidemiology of infections in burn patients. We can see that about 3/4, 76% of burn patients develop infection episode during their hospital stay. 39 of them develop bloodstream infection which can be fatal. 65% of pediatric patients also have developed at least one infection, being the pneumonia being the most common type of infection in these kinds of patients. The causative organism varies from the gram-positive, which are the skin colonizers, the Staphylococcus aureus, and the fearful MRSA, the enterococci, and the group A beta hemolytic streptococci. However, the gram-negatives, despite the fact that the gram-positives are the main cause of wound injuries in several patients, in burn patients, because we have to maintain the humidity, here comes the role of the gram-negatives, namely the Pseudomonas klebsiella and Acinetobacter baumannii. Also, we have fungal infection. Candida comes from moisture, and aspergillus and other molds that come from air and environmental contaminants, which is very frequently monitored in the ICUs and the burn patient. For the development of infection in any patient, we have to have this triad: the virulence of the microorganism, the bacterial dose sufficient to produce the infection, and the impaired host resistance. In the burn wound injury, despite the fact that the virulence remains the same of the microorganism, we have huge increase in the bacterial dose from the colonization of the burn wounds, which precedes the infection, and also the increase in the impairment of the host resistance. The patient susceptibility, as we all know, the patient has lost their first defense, which is the protective skin, and has a devitalized tissue, which acts as a very good media for replication of the microorganism. The intensity of care. These patients utilize in many invasive devices, many IV lines, intubation, ventilation, urinary catheters. So all these interventions help to evade the natural immune responses more and more. So the sources of the burn wound injury comes mainly from endogenous source, coming from the patient wound flora, namely the gut flora, or the fearful exogenous flora which comes from the hospital environment, mainly from hospital personnel, contaminated hands, breaks in the aseptic technique due to the intensity of care and being very busy, inadequate hand hygiene, which is the very underutilized medical service in our facilities, mainly Staphylococcus cocci and from the nasal carriage and skin flora of the environment. Also, the physical environment and the ventilation of the gut. Contaminated water tanks and water sources and the water used for the dressing change for the patient and the hydrotherapy tanks. The inadequate ventilation. When we design our burn units, we don't care about the ventilation system. We usually often utilize the ACs which are not centrally, which are not the HVAC system, having appropriate filters, and this is invite mold infection. We might have contaminated tools, items, and equipment. And the most important is the cross-infection from different patients. Because we attend in the busy room, the nurse and the doctors move from one patient to another, and inadequately, they might spread the infection due to their hands. It is very difficult in a single episode of infection to tell you what is the source of infection. It's multifactorial, and all of them may help in the transmission. The infection mode of transmission is mainly contact, whether direct or indirect. Droplet may play a role, but minimal. Airborne, which is the neglected part, is not very important yet. It helps in the dissemination of fungus and has caused many varicella outbreaks in the burn unit in which the patient is already having breaks in the skin. The type of infection, mainly we focus on burn wound infection, central line infection, urinary tract infection, and pneumonia. And this figure shows the comparison between a regular ICU and a burn ICU. In a burn ICU, the main focus is the burn wound infection. As you can see here, we have more bloodstream infection, more catheter-related infection, more respiratory tract infection and urinary tract infection than the regular ICU. First, the burn wound infection. It might be invasive or local, having different symptoms and signs from the localized symptoms and signs of cellulitis or necrotizing infection and fasciitis. There are several risk factors. First, burns involving greater than 30% of total body surface area. If we have full thickness burn, if there is failure to cover the burn or skin grafting, improper early burn care, which the patient comes delayed to our department, immune suppression, extreme of age, and other comorbidities as obesity and diabetes. The pathogenesis. First, we have a vascular wound bed, which is an excellent media for growth, and it also prevents the administration of systematically administered antimicrobial drugs. And all of my colleagues here, when they discuss the infection, they address that we are going to give antibiotics. It's not the magical wand. First, the burn wound becomes colonized with the flora, which is gram-positive, followed in about 1 week by the gram-negative from our hospital environment and disinfectants used. And in our hospital environment, we suffer from multi-drug-resistant organisms, so they are transferred to the patient and they make the treatment progressive and difficult to treat. After the wound closure is delayed and the patient becomes infected, requiring more aggressive treatment with more broad-spectrum antibiotics, which complicates the problem of multi-drug-resistant organisms. The complications of delayed healing, which encourages scarring, which causes which encourages scarring, causing problems in the mobility of the patient later on, and progressing into bacteremia and sepsis and the multi-organ dysfunction, as my dear colleague Dr. Rania said, which is preceding this. The prevention of wound burn infection includes assessment of the wound with each dressing to choose the type of dressing, whether it's a debriding dressing or protective dressing or the need of surgical excision. This is done under strict aseptic conditions utilizing maximal barrier techniques. Here, the question is to isolate the patient or not. In our departments and the isolation facilities is usually is mandatory for patients with large burn areas, like private rooms with enclosed bed space. We might utilize laminar airflow units with special ventilation requirements, or placement on a private room on contact precautions, especially for infected patients with multi-drug resistant organisms. Single rooms delayed colonization by 10 days, which is very critical in the wound healing and the early wound healing and improves the outcome. We should have separate nursing staff for infected and non-infected patients. Supplies should be arranged to the maximum, and physician, if we have one physician, he should care for the non-infected cases before the infected cases, to avoid, of course, the lapses in infection prevention and control and the cross-transmission. The environmental issues. Here, we should have clear and strict guidelines. No plants and flowers are allowed. Pediatric burn patients for psychological rehabilitation, we need like toys, but these toys should be washable with clear disinfection protocols. Routine environmental surveillance, and we are going to discuss that because many of our clinicians ask about to take samples all the time. And it is not really recommended except from the hydrotherapy room and the common treatment rooms. We shouldn't sample the environment all the time. The environmental antimicrobial agents, of course, we encourage the utilization of the topical antimicrobial agents. However, the systemic antimicrobials should be targeted according to the culture resin and according to our local antibiogram in the context of our stewardship activities. There should be a program of antimicrobial stewardship in the facility. The diagnosis of infection is very tricky because you know the fever and the leukocytosis from the inflammation can mask the sign of infection. Thrombocytosis is usually apparent, and nearly 15% of the patients are febrile in the first 72 hours. So how can we diagnose the burn wound infection? Cultures? No. Clinical examination and culture data hand in hand, because quantitative biopsy and quantitative swabs are very tricky to handle and may not be present in our normal microbiology lab. Tissue histopathology is mandated for quantification and evaluation of infection and the involvement of the non-burned skin. However, alone, without the clinical criteria, they cannot be used for the diagnosis of infection. So, if we are not going to utilize our culture results for the diagnosis of infection, why do we utilize it for? We utilize it for provide early identification of the organism, which can tailor the empirical and guide the empirical therapy, monitor the response of therapy, and evaluate the nosocomial infection transmission between patients, and we can identify outbreaks and cross-infection between patients. So it is very important. However, it is very challenging and cost-effective. The routine surveillance wound culture is recommended for patients and should be obtained when patient is in the unit. It is recommended to be at early admission and at least once weekly. Some organizations recommend it is done more than that. However, throat admission culture should be done to our pediatric patients, as 5% of the population are colonized with group A streptococcus. Surveillance for the environment and infection reduce the morbidity and mortality. Surveillance is following all types of infection according to a set of definition to identify our infection rates over time, the trends, and evaluate the current effective treatment. Culturing of the environment is not recommended. Environmental culturing is only needed if outbreak is suspected and the help of the infection control to evaluate the culture results is mandatory. We can decrease the bloodstream intravascular infection by following the bundles and the site choice and the dressing change. The pneumonia also is decreased by healthcare-associated pneumonia, or ventilator-associated pneumonia is also increased by the use of bundles. County, which is the simplest form of infection, can account to 2% to 4% of bacteremia and can be fatal, so also it needs to implement the bundle. We have components of the IPC protocol, which is the care of the unit, environmental control and cleaning, and the care of the bed space around the patient, the care at the point of staff contact with each and every patient. We have the care of the dwelling devices, the external devices as the IV lines, the suctions and everything. We have to improve the health of the patient to prevent the endogenous infection and improve the nutritional status and the gut flora, and finally for the detection of epidemics. Thank you so much.